Hello, everyone. Thank you so much for staying for this session. We're looking forward to some very interesting talks. So we're going to have 6 speakers. Each speaker is going to speak for 10 minutes, and then we'll have a 15-minute panel session. And hopefully we'll get some questions from the audience. So to get started, just going to go ahead and introduce our first speaker, who is Patricia Fabian. She's an associate professor of environmental health in the School of Public Health. Patricia.
Thank you. Hi, thank you for the invitation. I'm going to be talking about a project called asthma, so the asthma simulation tool for housing and medication adherence. I want to start by acknowledging the team. This is going to be showing a lot of work that a lot of doctoral students, postdocs, and research assistants, partnerships with pediatricians over at Boston Medical Center, National Institute of Technology, BDAC. There's sort of a lot of partners that go into this project. I'll talk a bit about asthma. I'm sure you all know. It's a chronic lung disease. It inflames and narrows the airways. It causes recurring periods of wheezing, chest tightness, shortness of breath, and coughing. The causes are still unknown, and there's no cure. The picture here kind of shows you what happens when someone has an asthma attack. The airways narrow, start producing mucus, it's hard to breathe. And then the graph on the right just kind of shows you that there's disparities around who actually has higher prevalence of asthma along sort of children, adults, males, females, and then across different racial ethnic categories. It's increasing in prevalence in the US. It affects around 25 million people, about 6 million children. About 1.8 million people visited the ER because of asthma in 2016, and it cost approximately $82 billion a year. It's kind of one of the annualized estimates of what the cost of missed work and school days, related mortality, and medical costs, so this combination. So in this grant, our focus is on, environmental health, so it's environmental triggers of asthma, and a lot of focus is on the indoor environment. Why? Because we spend 90% of our time indoors. So if you think about your house and things that could trigger an asthma attack, we have things like environmental tobacco smoke for households with smokers, outdoor air pollutions, which can come inside the home. If you live close to a busy road, for example, it's important. Combustion byproducts, so if you have a gas stove, you're burning the gas that gives off NO2, particles that just come off from cooking, regardless of whether you have gas stove or not. Biological things, so things like spores, allergens, things like mouse allergens or dust mites or cockroach, and then things like viruses, virus infections also trigger asthma attacks. So a lot of things indoors that then lead to exposure to a child and then lead to an asthma attack, hospitalization, ER visit, and then there's a cost. The complexity doesn't stop at the indoor environment. There's a lot of things about caregivers, for example, that can impact asthma management, medication. Again, there's disparities in what the asthma rates are. Things about the neighborhood, so things like crowding, violence, crime is sort of an indirect impact by kids maybe not playing outside quite so much. Green space, so there's that. And then if you want to take sort of a big macro view from a systems, there's things in the world that happen that impact asthma. So here is sort of, if you think of just ventilation and indoor air pollution and all the different forces around housing affordability, energy efficiency, climate change, all the different things that can also impact asthma. So for this grant, we're trying to take the system science approach to asthma exacerbations. What is system science? If you're not familiar, it's a family of analytical approaches used to characterize complex systems. So this is so you can evaluate individual components of the system. So really it's used for interventions, for policy analysis. This is what our asthma model looks like right now. It's got all these different modules. So it starts obviously with kids having asthma. They live in houses. So we have, I'm going to kind of explain the modeling that goes after this. So different types of homes. There's a module that's about pollutant exposures, so generating profiles of things like nitrogen dioxide, particulate matter, humidity, mold, allergens. That links to lung function, so how can that impact a lung function? And then if your lung function decreases because of exposure, say, to an allergen, how does that change your probability of having an asthma attack? That changes your probability of going to the doctor, maybe ending up in the ER, in the hospital, et cetera. There's these other modules that are about medication prescription and adherence. The neighborhood contextual factors, so things like income, crime, racial segregation, crowding, et cetera, and then social adversity and individual risk factors. So the idea with this model is to link a lot of databases so we can think about asthma in kind of this very system science way. So I'll talk about the data sources and kind of in this give examples of where we'd use different data science approaches. But what I'd love is for people to be thinking of ideas of how we can do this better, because we've really only scratched the surface of what we can do. So the first are electronic health records. I'm going to talk about that. This is from Boston Medical Center. So BMC is the largest safety net hospital in New England, primarily serves low-income minority urban populations. Bill Adams headed this big initiative to create this Massachusetts Health Disparities Repository that has all kinds of information. So what we did for asthma is that we got funding to create kind of a slice of that that's just for kids. So it's a slice of that Massachusetts Health Repository that includes things like geocoded addresses, sociodemographics and behavior, ICD-9, ICD-10 codes, which are diagnosis codes, insurance information, lab results, so things like lung function tests or blood tests, prescriptions, visits, so emergency room, inpatient, outpatient, primary care, vitals, et cetera. So I'll go a little faster. One thing we're doing is creating phenotypes, computable phenotypes from that electronic health record data, which is something you have to do to standardize kind of definitions of data that you get from electronic health records. It's a way to kind of transfer knowledge is one thing and to kind of standardize, standardized definitions. There's something called an emerge network that actually saves these phenotypes. There's only around 70, but it's so that we're not all creating a phenotype for asthma. Once you've created it, you validate it, and then you put it in that database. This is what ours looks like so far for asthma severity, kind of with the first iteration. So it's pulling data from the EHR about medication. This is actually a lot more complex than this. Or if you classify it with diagnosis code, or if you do it with labs, so with lung function. And then what we're doing is trying to look at what the overlap is if you only use one versus the other, and this can inform clinical care. EHR data is complex. It also is a little skewed, right? So for example, lung function, we have a lot more lung function metrics for severe asthmatics. So we need to find a way to balance that so that if you look at a distribution of FEV1, which is a forced expiratory volume in 1 second, so how much air you can breathe out in 1 second, that we can calculate that for everybody when you're making a cohort, an epi-cohort from the data. So this is some work that Dave Reynolds is doing using these statistical methods to kind of impute both asthma severity and lung function, kind of putting together all different databases from EHR. So this is using exclusively EHR data. The second data source is from our Environmental Health Disparities Center. And here what we did is we compiled lots of GIS information that could be related to asthma. I'll talk a bit about green space. So we're downloading all kinds of remote sensing data sets and thinking about how to process them. So the machine learning to say, are you a tree, are you a bush, are you a grass, et cetera, and then how that links to health. This is another project using Strava data, which is activity data, to say, okay, now we know the green space. Is it associated with physical activity? Is it associated with reductions in temperature? Is it about pollen exposure? Not all green space is created equal. And then finally, the third piece is the housing piece, which is using these simulation models. So first it's taking the address from the Boston Medical Center. We know where kids live. That means we can match it to the tax assessor's database and see what type of home they live in. Can match it. This is just an example of a house, not for my patient, but just a house. Looking at, for example, number of units, what year it was built, et cetera. We can then match that to these templates from building simulation software that combines Energy Plus. So Energy Plus is a software that the Department of Energy puts out that calculates very fine scale energy use. It links to Contam, which is a different software that NIST puts out that calculates indoor air quality, also at a very fine scale. So we can say, kids live in this type of house, we can match it up to the template, and we can actually calculate what their profiles of exposure are for NO2, PM2.5, relative humidity. So again, some of this is also machine learning to try to match up. Is the roof, is it a peaked roof, is it a flat roof, things like that. So image processing. And then finally, the final step of this is kind of putting it all together, right, and building this whole big model. So for that, we're exploring Bayesian hierarchical modeling, but we're still kind of thinking through what the best way is of linking all these different data sets, because at the end of the day, what you want is to be able to say, if I change something about someone's house, how will that impact their asthma? If we do something about their neighborhood, around sort of crime, like in public housing, putting in cameras reduce the level of crime. If we do something about community workers and reducing stress on caregivers, which increases medication adherence, how will that impact asthma? And then how will that impact cost? So I don't have a punchline yet because we're only in year 3 of the grant, but would love to hear ideas. And I think we're out of time, but I had an example of kind of how we did this before, but I think I'll just end there. Thank you.
So our next speaker is Greg Cohen, who is a statistical analysis of epidemiology, or statistical analysis in the epidemiology department in the School of Public Health. Welcome, Greg.
Thank you so much. It's really a pleasure to be here, and I'm excited to tell you about some of the work that I've been doing. First of all, I want to call out some of my collaborators that aren't here, Sandra Galea, the Dean of the School of Public Health, and also Sailesh Tamrakar, who's a programmer that I work with on this. So I'm a statistical analyst and also a lecturer, and I'm going to tell you a little bit about how we can use simulations to improve population health, and we're going to focus on disaster situations and how people can recover. So this right here is a picture of Hurricane Sandy right around the end of October in 2012, right before it made landfall in New York City and in New Jersey. And what this hurricane brought with it was about $20 billion worth of damages, essentially 300 homes destroyed in the New York area, thousands that had serious damage. There were about 150 people killed and 50 of those in New York. And in addition to all the disruptions to day-to-day life, transportation, and so forth, PTSD, which I have highlighted here, is one of the things that I'm interested in. So PTSD is a disorder that follows the exposure to a traumatic event and includes re-experiencing symptoms that, in other words, re-experiencing of that trauma, hyperarousal, difficulty with sleep, and it can really be a devastating illness to deal with. But before we get into that, I'm going to show you a little bit about the atmosphere and what it was like to be in New York and the surrounding area following this storm. So here's a picture of Manhattan with the lights out in the downtown area, which is very strange to see if you've ever spent much time in New York. Of course, the subways also shut down for a full day, the only time that's happened in New York City history. You can see here the remnants of an electrical fire due to flooding that destroyed homes in the Breezy Point area of Queens. And here you can see Staten Island, which is just filled with objects, just refuse. And so really there was a ton of work to dig New York City and the area out of this storm. And so as somebody who studies mental health and mental health particularly, my question is, and as somebody who focuses on mental health services, my question is, how can we improve population health following a storm like this? What's the optimal way? And the model that we were interested in looking at is something that's called stepped care. Now, stepped care is a very simple model. Stepped care says that what we're first going to do if we're trying to treat post-traumatic stress is we're going to identify people who are full-blown cases. In other words, people who have met clinical threshold for the disorder. And then, once we have screened somebody, we're going to, if they do represent or meet criteria for caseness or having post-traumatic stress disorder, we're going to give them and refer them to a clinical level of treatment, cognitive behavioral therapy. If they don't, we're going to refer them to a psychoeducational type of treatment called Skills for Psychological Recovery. Now, that lower level sort of treatment is what New York City, in fact, did following the storm. They had a one-size-fits-all, just like this. And now stepped care models have been used in a lot of different medical practices, specialties, and orientations, but they haven't really been used in post-disaster care. And it can be a very difficult thing to try to show and do in reality this kind of trial. And so what do we turn to? So we turn to essentially a simulation. As I don't really need to convince this crowd, you can really learn a lot by creating models in a virtual world from using real-world inputs, and then you can take that information back to the real world. So that's exactly what we did here. We initialized a micro simulation that included parameters on inputs of symptoms. So in other words, the symptom distribution that folks had following the storm. We did our own observational study, and we included those data. We had data on whether people would take up services from a World Trade Center study that took place in New York City. We had inputs for treatment from a randomized controlled trial, and we had demographics from the American Community Survey. So, you know, basically, just to give you sort of the breakdown in terms of how these subjects run through our simulation. If you're an agent in this simulation, you have a symptom score, and that symptom score reflects exposure in the borough level and also demographic factors. You can access care, and you can discontinue care. If you access care that will reduce your symptoms may get better on their own. And finally, if you recover and remit from PTSD, your caseness may come back, or you may essentially get a relapse of post-traumatic stress disorder. And when we did that, and we looked at starting with all people with post-traumatic stress disorder, you can see the usual care is in the dark bars, and the stepped care is in the light bars. You can see that it starts to diverge around 6 months, reaches about a height of about 32 to 33% difference in recovery at about 12 to 15 months, and essentially was superior to stepped care in terms of, to usual care in terms of treatment. It was also cost effective, and it also improved the reach or the access that individuals got in terms of seeing anybody. So we also then worked on a second model that was focused on essentially people with income loss and who were vulnerable, you know, and who may have experienced housing displacement, essentially. And so within this model, we included an additional treatment component that would target these folks and would target their access to resources, housing and income. And we wanted to see how, assuming that these factors relate to mental health, which we have good data show they do, we wanted to see how how the use of a social services case management treatment would work. And what we did was we tied the effectiveness of treatment, including clinical treatments and also including natural decay of symptoms, to whether you were at home and whether you had income decline. So if you're at home, you have essentially 100% effectiveness on all of those treatments, including natural decay. If you had income decline but were still at home, your effectiveness was about 95%. If you had income decline and were in a shelter, now treatment's working only 60% of what it would work if you were at home. So essentially, you can see how these features are linked together. And this just shows you just a brief look at a state transition map showing you, so everybody on this side has post-traumatic stress disorder, and people on this side do not. And you can go essentially this shows the pathway from the worst state, being at home and having no symptoms. What we found is that when we looked at stepped care with social services case management compared to stepped care without it, we found that at 1 year we had about 25 cases per 100 more remitted under stepped care with social services case management, and we see that the other treatments catch up, but certainly for folks with economic loss and displacement, this does seem to be the best treatment in terms of treatment effectiveness following hurricane. And so what we take from this is that stepped care for early treatment of PTSD after a disaster appears to be treatment effective, cost effective, is certainly more expensive, which I didn't show you. So that's another thing that policymakers will want to keep in mind. And in addition, we found that adding a social services case management approach improved recovery for people with income loss and displacement. What we take from this is that these results provide further proof of concept for a stepped care approach, and we think that this information should be taken and at least trialed in the real world, even if just incrementally in a small way, to see if our findings sort of jibe with real world findings. And that is all I have to present today. Thank you very much.
So our next speaker is Nina Caesar, who is a postdoc at BDAC in the School of Public Health.
Hey, thanks, Elaine. I'm really excited to be here. I'm really excited in general that BU is fostering this data science community. I work with a lot of researchers and faculty and know a lot of students who are really sort of challenging traditional thoughts about what it means to do social science research and using innovative sources of data. So it's awesome that this is still happening, and I appreciate you guys inviting me to speak. So I'm going to be talking about demographic complexity in social media data. And I want to cover a few things in this talk, all of which are grounded in this idea that the data that we pull from social media sites comes from people, and that there are unseen processes that generate those data and provide them to us as the researcher, decisions that get made. And I'm not just talking about content, I'm not just talking about posts, I'm talking about even that sort of impersonal seeming metadata that you get as this big block that includes stuff like posting time, like the color of someone's profile. There are decisions that are made by people in order to put that data in a spot that you can access and research. So I want to go over briefly some uses of social media for health research. I'm going to go over it a little bit quickly, and I'm happy to talk to you all about that later, or you can talk to my collaborators who I'll mention at the end. I want to focus in on this idea of demographic variation in social media, focusing in on this word bias and what bias means, how we're interpreting it, and how that shapes our sort of plan of attack. And I want to sort of conclude by talking about research ethics and limitations in working in this digital field and what we can do to create a potentially more equitable research environment for ourselves and for our participants. So I like to show this photo just to sort of get a feel for scale and scope. What we have on the left here are every geotag tweet from mid-2011 to 2014 compared with 2010 global population density. I did not create this map, Eric Fisher did. There's a link at the bottom here. And even though there are differences, what we can see here is that there's a little bit of similarity in the patterns that pop up, right? So there's a lot of filtration effects. You know, this is only Twitter users. This is only people who geotag their tweets. So even with that, we're seeing a lot of sort of similarity in these distributions. So we get a really strong signal with these data. And I'm not going to be a snake oil salesman and say that they're perfect, but they have a really interesting and unique signal. So what can we do with these data? So existing research has suggested that we can use social media data because of its temporal longitude to do things like track infectious disease outbreaks, to track health conditions over time. My team, as an example, has found that the number of food and exercise tweets at the US county level is associated with obesity at the US county level, even when we're controlling for demographics, even when we're controlling for built environment characteristics. And what we have here on the left are maps that show CDC estimated county-level obesity for males and females, and on the right are models that use tweet volume, select demographics, and a couple of built environment characteristics, and they generate really similar patterns. We can see concentrated areas of obesity as we would in these CDC maps, which is all to say there is some really strong signal here that we can leverage as health researchers for our benefit and for the collective benefit. Another sort of great thing about social media is that they're unsolicited, right? So it provides access and it provides insight into health topics that might be sensitive or stigmatized. For example, thoughts and experiences surrounding miscarriage and pregnancy loss. What we see here in these boxes here are coded sentiment, qualitatively coded sentiment for tweets in which people recount experiences of pregnancy loss. And what we see on the right here are trends in discussion of miscarriage and pregnancy loss over time. And if I were a clinician, for example, and I were going into a session with a patient who had recently experienced this, I might want to know a little bit about the background, how they're interpreting this topic, what they're seeing online, what the conversation in general is like regarding this. So there's a lot of richness in social media data that benefit us as health researchers, one of which is this temporal granularity. We can track trends over time. We can watch disease outbreaks. And although the data are not perfect, they offer us a really strong and unique signal. They're geographically granular, so a lot of tweets, a lot of posts are geotagged. Yelp reviews are linked to location. We can sort of hone in on small area estimates in a way that might take years worth of surveys to provide a really solid number for. Furthermore, they contain qualitative detail. So they have posts, they have content. We can see not just people's sort of temporal activity or geographic activity, we can see what they're thinking, what they're doing from a firsthand perspective. And that lends us a really unique lens. So the thing you're probably thinking is, who's posting? What are the characteristics of the people who are posting? So there's the you that you are in your daily life, and there's what you choose to show online, and there are decisions that are made that sort of gets you from point A to point B, right? And when we're gathering data from social media sites, we're really only getting the point B. So it requires us to think about the processes and the decision-making that goes into sort of creating the data set that we gather from a site like Yelp or a site like Twitter. So the sort of mechanics of how do we predict demographics is one big question, and it's one that machine learning specialists have explored for years and are continuing to build upon in really awesome, unique ways. So we can think about using metadata and methods to predict user demographics. From a metadata standpoint, we can sort of roughly characterize the sort of features that people input into these models as relating to people's networks, who you're connected with on these social media sites, the content, what you're posting in terms of text, and your profile metadata. What's your background color? Do you have a header image? Do you choose to show a profile image? And in terms of methods, we can sort of very roughly categorize these as being related to data matching. So maybe we can match apples to apples. If you're choosing to provide your real first name, we can estimate your gender with some level of certainty. Machine learning using content and metadata. So can we pull out features from your profile and from the things that you post in order to predict who you are from a demographic standpoint? And of course, facial recognition technology. So are there sort of deep learning classifiers that can sort of take, pinpoints, locations on your face and sort of get an estimate of what your demographic features are based on a set of training data? So this is not just a mechanical question, right? Sorry, I should take a step back and say, so what does this mean for us as researchers? What can demographics show us? Well, it adds these sort of richness to our data. So we're not just getting reports of what people are doing on social media. We can break that down by things like age and gender. So here we have reports of physical activity posted on Twitter, broken down not just by geographic region in the US, but by gender. And we can see what activities seem to be of interest to different people based on these characteristics. And this is an open field and something that we're sort of just dipping our toes into, adding this level of complexity that gives us this unique insight that we haven't had before. But we all know that your demographic characteristics are not just a box you check on the census. They're related to your identity too, right? They influence how you move through the world. And we know that identity matters online. We know that it matters in two sort of unique ways. It influences your self-presentation and influences how you curate an online identity, right? Even in spaces where transparency is sort of at the forefront, like Facebook, where you provide a lot of detail, you're still making decisions about what you show and don't show. It also influences who you connect with and what your community is. So this might be important if you're, say, gathering data based on a hashtag. You might ask yourself, who's participating in that conversation? Are there boundaries around it that I don't see? So I like to show this quote. It gets us this idea of why demographics and this intersection of demographics and identity is important. And it's important because the internet is not a neutral space. And I love this quote because it's super cute. Back when the internet was starting to become sort of commonly popular, a pamphlet for surfing the web said, "The internet lets all kinds of computers and humans talk to each other. The old barriers of sexism, ageism, racism are not present. Since you can't see with whom you're speaking, you get to know the person without preconceived notions about what you think he is going to say based on visual prejudice you'd have, no matter how innocent." So it's getting at this idea that, okay, what if the internet's this place where we can all come together and be friends? And we know that's not the case and that our identity still matters online, even in non-embodied and embodied spaces, right? So considering demographics and considering the ways in which demographics link to identity should be at the forefront of our minds as social media researchers. And some preliminary work suggests that, there is demographic bias and that this bias could be in some way related to feelings of vulnerability. So some of the work that I've done on Twitter has suggested that your likelihood of providing an identifiable name, a first and last name in your Twitter profile that I can search, varies by race and by gender, with white males being most likely to share this information and black females being least likely. So that kind of invites us to consider, in addition to just identifiable name, what else might this influence? What am I missing when I get this data set from Twitter? And how does this sort of shape the way I'm thinking about research ethics in the context of my work? So I've kind of talked about bias from a mechanical standpoint and bias from a sociological standpoint. And these two sides are obviously not mutually exclusive. And I think this is most heavily embodied in recent research suggesting that there is evidence of colorism in facial recognition classifiers. So here we have some error rates on facial recognition classifiers, commercial classifiers, from a paper that was presented in FAT 2018 that suggests that classifiers, most of these classifiers, are least effective on darker skin, and they're least effective on females with darker skin. So what are the ethical implications of obtaining the training data to build these classifiers in the first place? And then what are the implications of using these classifiers in everyday life? How does this shape our experience? So there are sort of two forms of bias here that I'm encouraging us to think about. One is this mechanical bias that's defined in terms of the data set, in terms of our sampling, or our model structure. But there's also this sort of social bias, the sort of need to consider whether the training data that we're obtaining or the classifiers we're building and their effect are perpetuating discrimination, perpetuating prejudice. So we're kind of at this fork in the road where we're using these data-driven approaches to estimate and control for bias. There's two sides, two paths we can go down. We've kind of previously been skewing more towards the left on the what can we estimate side, what can this information tell us? And I would encourage this conversation to go a little bit more towards the right and think about what should we estimate and what is acceptable use. So to conclude with a few sort of suggestions, things that we're hopefully thinking about or talking about with our colleagues are, we can engage in interdisciplinary collaboration and think not just about the mechanics of our research, but on the ground sort of sociological, ethical implications of our work, how we're obtaining this data, what the effect of our research is. We can take administrative steps to ensure that people are a little bit more in control of their own personal metadata from social media, which I think is happening more and more. We can understand how people interpret the use of their data. We can sort of break down context-relevant norms and what situations is it okay, according to the participants, to use their data and what situations is it not. And most of all, we can hand the microphone to marginalized groups and hear their opinions on the sort of research that's being done and what we as researchers can do to make it more ethical, yet still effective. So if you want to talk to me about this, my contact is here. I have awesome collaborators. They have a lot of cool ideas too, so talk to them as well.
So our next speaker is Charlene Wong from the School of Medicine. She's an assistant professor of neurology. So let's welcome her.
Hi, everybody. Thank you so much for inviting me to speak today. I am an assistant professor of neurology and clinical neurointensivist. The only disclosure I have is that I was a recipient of the Peter Paul Young Investigators Award from Boston University. So as a clinical neurointensivist, I see patients in the ICU who have brain bleeds, who have large strokes, and who aren't able to breathe on their own. So when I look at these patients, I have to think about all of the amounts of data that's coming in terms of what their vital signs are looking like, what their exam looks like that day, what their history was at presentation, how their imaging was looking, what kind of biomarkers they have, and continuous rounds of EEG. And so as a doctor, I put all of that information together, and I try to make my determination of what do they have, are they doing better or worse, what should my management be going forward, and then what do we do and make decisions. However, am I really able to look at all of that wealth of data that we have in the ICU? Or did my own personal bias that comes from just being a human lead me to not make the best decision because I'm not looking at this as objectively as I might? Maybe I'm putting more weight because I'm looking at the sodium trend going up and I'm missing the fact that if platelets and white blood cell counts go in a certain direction in a certain way, that perhaps they're getting an infection. And I didn't look back over the period of the last couple of days and I've missed that, or I did not put antibiotics as early as I could have. There are thousands of ways or permutations in which this could happen, and I am only able to focus on so many things at one time for each particular patient. So then the question is the holy grail in ICU or medical data in general, the ability to use our advances in processing speed to improve how we integrate all of this data and help us synthesize some of it. Now, you guys might have seen this type of cartoon before, but I really like it, and I think that it gets back to a lot of things that I think about. We reframe data science, artificial intelligence, and machine learning in this way, and especially for my medical colleagues, it's this new thing that's coming out. But what machine learning is are classical statistical models are machine learning. It is the idea that we are minimizing a loss of function so that we can learn data. And so this is basic concepts that we've used for the last 50 years. Nevertheless, we keep seeing it come up. People are looking at big data in medicine. They're looking at machine learning in medicine. What can it do? How do we design it so it's fair? What is machine learning in medicine? So what are some of the advantages? You guys have heard about a lot of these. You probably know all of these already. It's a mechanism to analyze large data, images, diagnostic studies, genetics, electronic health records that we can get from a lot of different places. It's a mechanism to analyze heterogeneous data. There's the promise or potential of combining free text, images, structured data. We could potentially automate our workflow so that we can ease the burden on practitioners. However, that's what they told us with electronic medical records, and I can tell you that most doctors won't say that's eased their burden. Can we standardize care throughout tertiary and non-tertiary centers, or maybe even improve care? That's a standing question as well. So there's a lot of increasing interest in using machine learning techniques and automated techniques. Can we detect atrial fibrillation or arrhythmias? Can we detect malignant lesions in the breast, in the skin, on pathology? All of these seem like they can be enormous advances, and they very well may be if we can integrate them appropriately. So what are the pitfalls? We've talked about a lot of these pitfalls. Bias propagation. Are we propagating bias, and are we able to apply the results in a way that when they are done externally, that they give us accurate information? Interpretability. How can we actually learn from what these results are or what the classifications are so that we can improve and advance our understanding of human disease? Reproducibility, we've talked a lot about that. And accountability, who's going to be accountable for all of these things? However, I would argue, especially to some of the medical field who views machine learning with both fascination and trepidation, that these pitfalls are the pitfalls of science. They are not the pitfalls of machine learning. We have had biased data sets, and we've been using them with logistic regression or linear regression or however else other classical statistical models. We've always had to be careful about what we're putting into our data so that we can determine, are we getting reproducible results? So how do we overcome obstacles? Big data is not a substitute for hypothesis-driven research. We need close interdisciplinary collaboration and communication between clinicians and computer scientists. We need good mechanisms for external validation, and we need careful data infrastructure planning and management. So one of such infrastructures that I've worked on is a particular project in which we're looking at the complications or the early complications of large acute strokes. And so when we've designed this with some of our collaborators, we've had a couple of different parts. We have to identify our outcome. We have to figure out what our inputs are going to be. We're going to try to evaluate this with prescriptive medical recommendations and have to validate that as well, and then also combine other sources like computer vision, which is another entire project in itself. And so I'm going to discuss with the remainder of my talk the first part of this that we've worked on in our project. So machine learning and natural language processing to identify our outcome of interest, which is going, or not our outcome of interest, my apologies, our population of interest, people with large ischemic strokes, or more specifically, people with large MCA strokes. So we have a good database of 17,000 stroke patients, but those aren't all the patients that we want to use. We want to use a particular subgroup. And I think that Dr. Fabian was talking about it earlier in terms of ICD-9 codes or ICD-10 codes as our way to classically identify those people or those populations. Anybody who's worked with ICD-9 and 10 codes from a research standpoint, we know that we compromise and use it because it's there, but not because it's good, not because it's helping us. So images are the gold standard for identifying people who have strokes. However, text is cheaper and easier to handle and process. Natural language processing has been used to identify pneumonia, breast cancer, and head CT abnormalities, and is better, or we hypothesized it will be better, than looking at ICD-9 and 10 codes. When we look at the way radiographic text comes, there have been people who have identified whether stroke has happened or not, but that doesn't give us much more information than the ICD-9 codes do. We want to know, can you tell us where the stroke happened, and is it acute? Because that is the population that we really want to study. And so we hypothesize that we might be able to accomplish this with simple NLP methods of just identifying stroke, but that more nuanced methods would be needed to find different stroke features. So we used a particular word vector embedding approach called GLOVE. There are others that are out there, but we also tried to train this on a relevant rich corpus, not just Wikipedia, but because radiologic parlance is so much different than the things that we use or the language we use in everyday life, we had a very specific set of data that we trained our algorithm on. And so we evaluated vectors using quality assessment, and this was our workflow where we took 60,000 CT or MR reports. We randomly sampled about 300 patients or 1,300 reports, generated hand labels for the presence of stroke, for the acuity of stroke, and whether or not it occurred in the MCA location, which is the middle cerebral artery. What we found is that when we used our word embedding approach that paired with a classification method of recurrent neural networks, that this had the best discrimination of all of our techniques. However, it's also worth noting that sometimes a simpler method can do the job. For just the presence of ischemic stroke, we found that bag of words, a simpler method, paired with logistic regression, did almost as well. So you don't need to use a machine gun when something that's like a pellet gun would be just as good. Or potentially we wouldn't use any guns at all. But that's another thing, or another discussion. We defined an approach that we wanted to tailor so that it could be tailored to look at different stroke features and that we could mix and match it. But we have to externally validate it. We have to increase the scope to other stroke features, like if the stroke has swelling associated with it, if it has small vessel disease, what other kind of locations, and whether it has hemorrhage or blood associated with it. And we also have to consider newer methods. So one of the pitfalls of working in machine learning is that there are always new developments. So since the time that we started using the word embedding approach, different NLP methods like Elmo and BERT have been increasingly used and been shown to be very good. So the takeaways. Machine learning is not a panacea, at least not for healthcare's woes. It's a promising tool, and it needs direction, deliberation, and communication. And so as clinicians, and data scientists, of course, we're certainly not out of job yet. Thank you for your time.
Our next speaker is Thomas Kepler. He's a professor of microbiology in the School of Medicine.
Well, it's great to be here. And I want to come to you from the point of view of basic science. So we've heard a lot about the uses of data science in the clinical world, and we do it also in the basic science world. And I'm going to try to squeeze a little bit of information along those lines into this talk. So my laboratory is primarily interested in antibodies. Antibodies are the proteins, let's see if I can figure out how this works. Antibodies are the proteins that first sense the presence of unfamiliar molecules. They signal this discovery to the B cells, which bear the antibodies on their surface. And once the B cells are activated, they'll secrete the same antibody into the serum so that they can then attach to the unfamiliar molecules and mediate host protection. So here's an example. Here's an example where we've got a virus, and these little red spikes are viral proteins that are used to attach to the cell, and the virus invades and takes over the human cell. What the antibodies do is attach to these viral proteins and prevent the virus from entering the cell. So that's one very simple example of the way antibodies work. It's really important to know that there are billions of distinct antibodies, different amino acid sequences in your body right now. And our task is going to be how to deal with that enormous variety. So here's how B cells and the genes that encode the antibodies come to be. The B cells derive from a progenitor stem cell, and they make the antibody genes by taking pieces of genes from the genome, cutting them out, and then splicing them back together. So the genes themselves are made stochastic. In other words, there's no sense for what they might bind once the proteins are made from these genes. And there's a lot that goes on during this time to ensure that there's no autoreactivity and so forth. But by the time these B cells are now floating around in circulation, if they happen to bang into something that they recognize, the B cell is activated and begins to divide many, many times very rapidly. And some of these B cells go into a little place, a little niche called the germinal center. And what they do here is they begin to incorporate mutations into their genes. And this is a Darwinian process. The B cells that encode antibodies that have improved binding have greater survival and die less rapidly, and so they begin to take over the population. And so what we do is to gather sequences from these, my thumbs must be too big. And so what we can do is we get the sequences from post-vaccination B cells and then infer those phylogenetic trees. So what we wanted to do was to determine what happens in between vaccinations. I won't go into it, but many vaccines require multiple immunizations, and this was learned simply empirically. And we asked the question, what is going on at the B cell level between these immunizations? And the best guess that anyone had was that there is a kind of competitive exclusion, that the Darwinian process is red in tooth and claw, and only the very best B cells make it to the end. And if you immunize again, you're starting from an even better batch, and they fight it out amongst themselves. Until the very end, you've got a really great B cell or a handful of B cell clones, and these guys win, and they become your memory cells. But that's not what we found. But what we had to do was to use a vaccine that you had to take 5 times in order to be protected. That vaccine turns out to be anthrax vaccine. And so this is the typical procedure for receiving the anthrax vaccine. You get dosed at time 0, 1 month, 6 months, 12 months, 18 months, and then you're protected. So what we did was drew blood 1 week after each vaccination, and we obtained about, we sorted out the plasmablasts. Plasmablasts are the cells that are just becoming the plasma cells that will secrete copious amounts of antibody. So we've got about 10,000 individual plasmablasts sequenced. They're heavy and light chains. The 2 pieces of the gene that is required to make the antibody, and then use the methods that we have developed to continue the process. So, well, I've just said that now, but the point is here that I want to admit to being somewhat old-fashioned in the way that I apply data science, and that is we use generative models based on our understanding of the phenomena in question. And so we understand recombination and affinity maturation well enough to have really detailed mechanical or mechanistic models of how they work. And so we use these to proceed, and I know that I'm going over these things much too quickly, but every one of these bands represents a single B cell clone. And the clones increase in size and then decrease in size. But the thing is that at no point does a single B cell clone ever dominate entirely. And that is exactly what we were expecting that they would. So let's just take a look at this one here. This one arises after the second immunization, dominates after the third, but then declines through the fourth and fifth immunizations. So so there's a huge amount of diversity at the end of the 5 vaccinations. And in fact, there's no real difference between the diversity after the 5th. And similarly, we can look at the level of an individual clone. So this is an individual clone. And what we did was we measured the affinity constants, or the equilibrium dissociation constants using surface plasmon resonance. And we see that we have gone from 670 nanomolar to 6.7 nanomolar, which is a 100-fold improvement, but that there's a huge number of different endpoints that have the same improvement, so that we are maintaining diversity even while we have a great deal of affinity maturation. I'm going to try to squeeze in all of the work that we've been doing for 2 years into 2 minutes. So what we want to do is now look inside the plasmablast, what's going on inside the cells. And so what we've done is we've recruited a cohort of 13 patients receiving the influenza seasonal vaccine. And again, we collect the plasmablasts. But this time, instead of just sequencing their immunoglobulin genes, we sequence the entire transcriptome and look for changes in the transcriptome before and after vaccination between different isotypes of plasmablasts, and importantly, to see whether they correspond to the evolution that occurs in the Ig genes. And I'm out of breath. And what we find is that we do find a number of differences. Now, by the way, the isotype itself cannot be determined until we do the sequencing. So that's part of the sequencing itself. And we can see how immunoglobulin A type cells respond differently from immunoglobulin G type cells and so forth. And this is the one that we are really most excited about. If we look at the affinity maturation, the frequency of mutations in the immunoglobulin genes, which of course we can't get until we've done the sequencing, reassembled the immunoglobulin variable region genes, and done the statistics on it, we see that the plasmablasts with high mutation frequencies and those with low mutation frequencies have some repeatable differences in the transcriptome. So older B cells are different from younger B cells, and that has some pretty important consequences for our response to influenza. I want to acknowledge everyone in the lab, and particularly Professor Fung, who runs all of the experimental work in our lab. The volunteers who each got stuck 20 times for anthrax, 15 times for influenza, we paid them. So, you know, come on. And these graduate students and technicians and software engineers, the flow core and the clinical heads for the 2 studies. Thank you.
Our last speaker is Belinda Borelli, who is a professor of health policy and health services research in the School of Dental Medicine. Welcome.
Thank you. Thank you so much for inviting me. So we're going back up to 40,000 feet, way up, more talking about population health and how to use data science to optimize and personalize mobile health interventions. So I'll be talking about using data science to optimize mobile and electronic health for data collection, intervention, and analysis, but also how using mobile and electronic health can help build data science through methods and approaches. And now, so these forthcoming changes in technology really need to, really necessitate this responsiveness in both data science and mobile health. And finally, I'll talk a little bit about BU's mobile and electronic health arc, and I won't have time today to talk about my own work, though. So there's a variety of different mobile and electronic health platforms, and the great thing about it is that more and more are becoming increasingly available to different, there's very little differences in race, ethnicity, and income in the use of these platforms. And so this results in very large, voluminous, scalable data. And for the first time, we have a way to customize and personalize interventions to large populations. The issue is, though, is we need sophisticated analytic techniques to be able to deal with these data. So, we all know the definition of big data, and I think we always think about it in terms of, electronic health records and patient databases and genomics and all the other omics, but really starting to think about big data with mobile apps, environmental monitoring, and social media as well. So as you can see, there's a lot that just resides in our smartphones, just indigenous to our smartphones, and then you layer on that various wearables and sensors and continuous monitoring. So all of this really results in a voluminous amount of real-time data that that needs, and structured and unstructured data that needs analysis. So let's talk about what data science can do for mobile and electronic health. So it can create agile and adaptive interventions to optimize those interventions, okay? So we talk about just-in-time adaptive interventions, or JEDIs. And so what that does, what these interventions, what data science can do is monitor and assess individual level variables, physiological variables, mood states, as well as the individual's context. And then the data can continuously and dynamically respond to the individual and changing the intervention over time and in different contexts. So, and then and we've moved away from using if-then rules to customize solutions to going into machine learning and having these dynamic feedback loops to adapt to individual needs and provide interventions just in time to people. Data science also allows for optimization of the user experience level. So what's engaging the individual in the intervention and with the mobile health solution, and so machine learning can learn that and kind of calibrate for what the individual wants and needs at the time that they need it. So on the other hand, mobile health can help build data science. As we talked about, there's a lot of different data types from mobile health, including apps, social media, medical imaging, diagnostics. But there's also things that accelerate mHealth data that we need for data science. For example, 5G is here, and so that increases bandwidth and decreases latency of communication. So with that comes new innovation and new inventions and many more connected devices. And so with that comes a lot more data that data science needs to deal with. So, and then you have diversity of data too from all of these platforms. So it's both structured and unstructured data. Another way, another instance of the symbiotic relationship between data science and mobile health is digital biobanks. So we have biological biobanks where we store raw specimens that we use later in the future. And so now the new innovation is digital biobanks. So creating, having digital biomarkers for future use. Now the issue is that a lot of these biomarkers are derivative digital biomarkers because they're too voluminous to store and manage. So however, you can't really process later the things that you want to look at with derivative digital biomarkers. So people in data science institutes are now coming up with ways to how to manage and store the raw data to better use them at a future time point. And I'll give an example of this. So we need robust, accurate, and secure analytic methods to accommodate these next generation devices that you see here. So an example of digital biomarker comes from the NIH MD2K effort. So this group, for example, invented a contactless microradar sensor that detects heart and lung motion to predict stress episodes in cardiac patients, craving in smokers, and relapse in cocaine use. And so they use time series pattern mining methods, and they built this platform for raw data collection. And so in my own work, I work on phenotyping smokers into different subgroups using latent class analyses and other types of analyses to be able to better match interventions to smokers to increase our success rate with them, and then using that, building an app, and then extracting big data. So in summary of this part, you can see that it's really necessary to integrate data science and mobile health using big data and using data to then create and customize and personalize interventions that are responsive to the individual and their environment, and providing interventions to the right person at the right time in the proper context. And then also coming back with this feedback loop and comparing disease progression or how people are doing to reference populations and iterating on that as well. So I wanted to talk a little bit about BU's mobile and electronic health ARC, which I've been heading up for the last 4 years. And our goal is to conduct state-of-the-art research and training in mobile and electronic health to improve health across the lifespan with an emphasis on underserved and vulnerable populations. And so we really want to foster transdisciplinary collaboration at BU, as well as develop a scientific vision and strategy for digital health at BU. And also I wanted to acknowledge my co-directors, Lisa Quintiliani and Tibor Palfai. We have 7 funded pilot projects and 11 affiliated projects across various mobile health platforms, focusing on a lot of different content. We have a steering committee that has cross-cutting cores, external advisory board, postdocs, and junior faculty, and now about 160 BU member affiliates. We have a symposium every year with industry and academia and participants, monthly seminars. We have our website, please come visit. And we do the typical publications and conference presentations and grants. So future directions for us is that we really want to integrate more into the data science initiative at BU. We are currently also building a lot of international digital collaborations. We have our annual symposium on Cinco de Mayo, and our next monthly seminar is tomorrow on assessing the quality of mobile apps for oral health content analysis and usability by Dr. Alaa Kauri. So in summary, integrating our ARC with the data science initiative is consistent with P4 medicine, so using data science to improve prediction, prevention, participation, and personalization of stakeholders in healthcare. And the needs of mobile health and data science really are symbiotic. And we need to leverage data science and mobile health to improve patient outcomes, because that's not yet evidence-based. So, and then finally, we need to figure out ways to translate data science and mobile health and our findings into meaningful and useful formats for patients and clinicians. So, thank you.
Can all the speakers go up and sit at the panel table? We're going to take questions. Any questions?
So thank you very much. This was very informative. It's like at us. It's unbelievable. We need a whole day for this. So I'm really interested in the comments made about how machine learning is not a panacea, and that you know, it needs to be informed. Let's put it this way. How do you see that reflected in academic programs or in training of students? Because there seems to be this divide of the tool-happy, software-happy, if you want, side of the AI machine learning, and then the application side, and then hearing, actually many of you, but the discussion on the fact that you need to have domain knowledge, basically, and to know what you're doing with the data. So how does one do this? In research, I can understand it, and you know, through training and so on, we can get people who can be good in both. How about undergraduate or even graduate level education? Can you comment on that?
I don't know that I'll be able to comment on undergraduate education, but I can say that there is a large culture divide within medicine in general in terms of people who are interested in using more advanced machine learning methods and those who are afraid of what its implications are. A lot of the common themes that we've seen today. When students approach me who are at the medical school level, they are usually the ones who are interested in computer science and interested in that background. But I think that those students are, at this moment, early adopters who are in the medical program, as opposed to that being a very common thing as we're going forward. But I think that increasingly we are going to see people who are more aware of these methods, the democratization of different software that people can use, will allow them to be savvier than many of the primary investigators who conduct research. But I think that we're going to be seeing a slow adoption because they are the ones who are going to be continually using their techniques and their philosophy to run academic medicine, at least for the time being. But I can say that even amongst us, there is hot, ongoing debate about young investigators who do have computer science backgrounds or who are interested in pairing with computer scientists and how we might use that to beneficially forward medicine.
I'm just going to make a quick comment. So for undergrad education, I think that the trick is to be part of an interdisciplinary team. So I think that a lot of people come super excited about using tools. So for the asthma project in particular, right, we've got the pediatricians, we've got the bioinformatics people, we have the super excited computer people, and then the environmental health. And it's taken everyone's input to actually move the project forward of saying, this isn't realistic, have you considered these other things? So I think for teaching undergrads, I think you have to make them part of an interdisciplinary team, not just pairing, but actually multiple people on the table.
Any other questions?
Thank you. That was very interesting. So I have a more methods question, and it sort of cuts across many of your talks, and especially when you're trying to integrate multi-module data. I'll take your asthma example, where you're bringing in health information, socioeconomic status, the household information, and so forth. Are there good practices for dealing with missing data? Because obviously you don't have every data point for everybody you're tracking, and for some people you have very rich data like lung volume, and for other people you have very coarse data like which geographic area they live in. I assume that that's a problem for everybody's data, where there's a lot of missing pieces, and what are good practices to deal with that? Are they sort of industry standard practices? And B, how bad is that problem?
So I can comment specifically on asthma. So there's missing data across different dimensions. So let's talk about missing data in electronic health records. So the way we handled it is doing fairly complex statistical methods. What you're doing is using information, lung function is the example. So forced expiratory volume in 1 second gets collected for more severe asthmatics, right? So you have a lot more measurements for severe asthmatics. You maybe don't have anything for intermittent asthmatics, except maybe sort of a handful. And so what you can do is use other information about EHR visits, primary care physician visits, prescribed medications, and put this all into this complex matrix. This is David Reynolds' work in the stats and math department, to kind of say everything else that I know about you can predict lung function, right? So now let's predict it for people that we don't have data for, validate it, do cross-validation, et cetera. So that's in electronic health record data. For other things like the publicly available data, so the nice thing about that is usually it's available for everybody, things like median income, household, right, block group, census tract, et cetera. And for people who move, for example, where you've got different assignment, then that's sort of a different project, kind of studying, are these movers churners, are they up and outers, are they, you know, like going to a better neighborhood, worse neighborhood, et cetera. So I don't know if there's a standard that I can tell you, but it's a good point, and you definitely have to think about it.
I'd say for social media data, obviously coverage is an issue because, you know, not everyone uses whatever source you're getting data from, so missingness is a big question. I'm going to say right now there's really no industry standard, but we can take steps. And one of the steps I think is kind of similar to the medical records approach, where you can kind of infer other things about this user and try to get an estimate of who they are demographically and maybe adjust your sample. But for sort of gaps in, you know, who's using this platform or not is kind of out of the control of the researcher, and you kind of have to bound your research question to accommodate it.
Any other questions?
I'd like to just ask one, and it doesn't need to be a long answer, maybe more sort of associational logic. So certainly going forward, you know, Azra and I and others will find ourselves in positions trying to figure out where can we help, right? And how can we help groups come together? How can we help facilitate things, move things forward? There's only so many hours in the day, so much time, et cetera. So if you think pain points of all those wonderful successes that we just saw, there must be some pain points underneath, right? I'm assuming. So just off the top of your head, what do you think in terms of pain points with respect to computing and data science?
Well, I've got one. So as I mentioned, our statistical analysis involves models, you know, sort of old-fashioned models with parameters. And I also claimed that they were mechanistically realistic. Now, that's wonderful, but it's also very, very slow. And I would love to be able to talk with someone who was a real expert at algorithms building and work out something non-trivial for doing this kind of analysis. You know, maybe doing several different passes over the data and getting coarse results, and then, but anyway, the point is that I think that even if you are using sort of old-fashioned statistics, trying to apply it to larger and larger data sets, I don't think should be impossible, but it needs a lot of work.
So I just have one idea. Let's say so like speed dating research, having some kind of event where you've got students and people interested in projects, and then have people pitch for 5 minutes ideas that they might have, and then you might be able to link the one's got the biology background and the computer science with something that you need, because sometimes it's hard to find people with the right expertise, and for those people to find sort of where there's needs. Just an idea.
Your idea was better than mine, but I agree very much with the thematic notion that we need integration. Anything that helps support integrating or having cross interdisciplinary collaborations. And so whether that's in the form of support, time for young faculty, for older faculty, for people who are interested in trying to get skills that they do not currently have, especially because it's a new and developing field. And at the same token, you need to be able to connect the data scientists with people who are content experts. I was at a machine learning for healthcare conference last August, and I can't tell you how many bright computer scientists who are using mimic data were making these fantastic models to tell me something that I looked at it and I'm like, I could have told you this without having done all of this. And so you really need to be able to connect both of those parties together.
terms of mobile health, I talked a bit about JEDIs, these platforms that are dynamically responsive to individual level and contextual variables. And I think we need more resources here at BU to help design and develop and analyze JEDIs, because they are highly customizable yet scalable to, you know, millions of people. And I think it's kind of the wave. And there's a lot of, we've done a assessment of the digital landscape here at BU and who is doing what, and the demand for these, I think, is going to, or has already far exceeded our capabilities here.
I know we've said interdisciplinary about 1,000 times, but I think for me, the rub is ethics, and what needs to be done is having more of a dialogue about, like, what can we do versus what should we do with passively collected digital data. So I think there is a lot of potential in these data. I think for things like sensitive health topics, as an example of something that's, you know, a really rich, unique window, but we have to kind of temper ourselves and think about, you know, the ethical implications of what we're doing with these data and how we publish and share results. There just needs to be more of a dialogue where we're sort of tempering ourselves and asking, with each new methodological development, with each new paper, with each new model, how are we handling the people in our study as we would handle human subjects research? So really taking a step back and balancing that that fork in the road, I think, is the big point, sticking point for me.
So I think some of this is actually we're starting to see some movement on this in the School of Public Health, but there's been some need to, I think from our perspective, try to integrate data that's passively monitored on, say, satellite and imaging data on storms, as we try to think about how we can predict essentially where there's going to be the most need for mental health services. So there's this kind of atmospheric data, and then there's also sort of Twitter data where we can perhaps get some sentiment analysis done. And so what we're trying to do is trying to combine those things as we move forward.
One other thing that I had thought of, one of the common themes that I've been hearing from the NIH, from the American Heart Association, is that they're not interested in fancy new models that are just making models. So I think that the next step, if you're looking forward after we get integration or all these wonderful things, is implementation. And how do we think through about taking what we've learned from using data science and implement it to change outcomes?
I've got one little anecdote that I'd like to share. It's a story that I find extremely important, and I think that it has some lessons for us at this time as well. Malcolm Rorty was, in the 1920s, an engineer and a manager at AT&T. And he was given, and he became the president of the American Statistical Association in 1930. And his speech given to that association upon his presidential address was telling about the time that he was tasked with putting together a group of statisticians for AT&T. Now, so in the 1920s, statistics was not yet an academic discipline. And so it's not like he could just, you know, looking for PhDs in statistics. And he writes about how difficult it was and how much time it took, and that they tried different strategies. And then in the end, he says, we found out that the best statisticians weren't those who necessarily knew how to compute a correlation coefficient, but the ones who knew intuitively when to distrust the correlation coefficient. And I think that's really important, and that's the first story I tell in my statistics classes to all of the biology students who are trying to make their way and decide just how much they're going to have to learn.
Great, thank you all.
So with that, we're going to end our session. Let's thank our speakers again.